The complete management of a patient with atrial fibrillation. Atrial fibrillation is when we have the atria, here are the ventricles, here are the atria, they are just fibrillating, so doing something like this. One part is contracting, then the other. It is not a synchronized contraction. So the symptoms would be most in patients that have congestive heart failure, some valvulopathy, or something that makes that they they need the cardiac output that comes from the atrium, that is only like 10 to 20, maybe 15% of the cardiac output comes from the atrium. And if we take away this in a normal patient, the patient would not notice it, would not have any symptoms. But in a patient, for example, on cardiac failure or with myocardial infarction, that the heart is not pumping well and they need everything, and then they develop atrial fibrillation, that is, we take 10 to 20% of the cardiac output, they are going to be symptomatic. Now, the relationship between congestive heart failure and atrial fibrillation is quite reciprocal, because the thing that can cause atrial fibrillation is every structural heart defect, like valvulopathies or cardiomyopathies, whatever. And this can lead to enlargement of the atrium, of the left atrium most of the times. Hypertension, valvulopathies, wherever. Also some toxins, maybe. Toxins, toxic, alcohol, for example, tea, caffeine, things that increases the demand of the heart, etc. Anyway, but with congestive heart failure, the patient can have congestive heart failure and then develop, because of this, atrial fibrillation, or the patient can have atrial fibrillation and because of this then develop congestive heart failure. Now, we need to be very careful when we are talking about congestive heart failure. Systolic heart failure, that is when we have a low ejection fraction. So now, the most common site of atrial fibrillation occurs on the pulmonary veins, or at the site when they join to the left atrium. On the EKG, we will see a irregular rhythm. We will see no synchronization of rhythm. That's the irregular rhythm. We will not notice it. We will see some QRS, we will see no pattern, and maybe we wouldn't see P waves, or we would see something called F waves. The F waves are like many small P waves, and we can see them or not see them, but we don't call them P waves, we call them F waves. And we should be careful of not confuse these, for example, with a tremor in a patient with Parkinson's disease, or just because the patient is nervous or something like that. We say that the atrial fibrillation is the most arrhythmia because it's irregular. The heart rate is very high. When we have a heart rate above 200, then we suspect that the patient has a accessory pathway, like in Wolff Parkinson White, that is aiding on this fibrillation of the atrium. Alright, next. If the patient is unstable in atrial fibrillation means congestive heart failure, chest pain, hypotension, altered mental status. If the patient has any one of these, or if the patient has less than 2 days or 48 hours, and it is not returning, then cardioversion. Cardioversion. Certainly, when the patient comes, and that is in the non-unstable patient, that is just before 2 days, we can give it a chance of try a little bit, but that is obviously depending on the patient. But certainly, if the patient, so this was cardioversion, we do electrical cardioversion, or could be electrical. We have electrical and pharmacological cardioversion. Now, if the patient is stable, the first thing that we need to do is the rate control. Rate control is between 60 and 80 beats per minute at rest, and between 90 and 110 beats per minute in not at rest, in moderate exercise. Patients that are stable can make this. We give AV nodal blockers in order to have this rate control. This would be calcium channel blockers, beta blockers, digoxin, for example. Now, digoxin is never the first choice unless the patient has congestive heart failure with systolic, with decreased ejection fraction. Then the first choice is digoxin, and then amiodarone. That is, now we have rate control. If the patient can maintain the rate control, that's fine. Now, the long-term management for atrial fibrillation is rate control plus anticoagulation. This is superior to rhythm control. That is, rate control just means that the patient continues on atrial fibrillation, but the heart rate is between 60 and 80. So we want that the patient goes to the home with a rate control and anticoagulation, because rate control, most of the time patients revert to that. It is more complicated in a sense, so we prefer to do rate control and anticoagulation. That's perfectly the same or better. If the patient has symptoms on rate control, or we cannot control the rate, the heart rate, or the patient is a young patient with normal heart, no structural problems, etc., then is when we will attempt the rate control. Now, the rate control is like cardioversion, so we call it electrical or pharmacological or chemical, whatever you want, cardioversion. The pharmacological cardioversion is with amiodarone, flecainamide, dofetil, sotalol. So they're practically, amiodarone, dofetil, sotalol are the class 3 antiarrhythmic, the ones that block the potassium channels, and flecainamide is a class 1 antiarrhythmic, blocks the sodium channels. In patients with congestive heart failure, we can only give dofetil and amiodarone, just these ones. Remember that the first option always could be digoxin, but if digoxin does not work, then amiodarone. In patients that are stable, we prefer dofetil above amiodarone. Alright. Now, for the elective cardioversion, this is elective. We have, first we need to see that the patient has more than 48 hours. Every patient with more than 48 hours of atrial fibrillation also needs the anticoagulation. So here we have two options. Either we first do a transesophageal echocardiography to see if there is some clot. Now, depending on what we see here, if there is a clot, the patient needs heparin and warfarin. Remember that the heparin is for the window of warfarin, while the warfarin takes the place, because warfarin at the beginning, remember, that has the opposite effect. Now, if the patient has no clot, then we do cardioversion and then 6 weeks of warfarin. So routinely, patients that just are taking anticoagulation with warfarin or whatever it be, that is just for prophylaxis, they don't need the heparin. But in patients that they already got the thrombi, then they need the heparin. So here we just have transesophageal echo, then cardioversion, and then 6 weeks of warfarin. That's it. The heparin will only be used if we have found a clot. The other option is we give the patient 3 weeks of warfarin, then cardioversion, and then 6 weeks of warfarin. Warfarin or Coumadin is quite the same. So in either case, the patient would have warfarin for 6 weeks, and before and after the cardioversion, we need to anticoagulate the patient, unless here in the transesophageal echo we are seeing directly if the patient has a thrombi or don't. But after the cardioversion, we need to be sure that the patient is not going to have one, or at least to have more confidence. So we will give 6 weeks of warfarin with a INR of 2 to 3. So that's it. Is the treatment is for a patient that is unstable, is synchronized cardioversion. A patient that is stable, rate control. Then we can try rate control for patients that are young with no structural problem, patients that are symptomatic on rate control, or patients that cannot be controlled with rate control. We cannot control the rate, so we would give rate control. We will try rate control, and we could also try ablation at the site of the foci, and certainly after that we will need to give also anticoagulation with warfarin. But this is also if the rate control is not achieved. The cardioversion, elective cardioversion, remember, could be pharmacological or electrical. In either case, the patient will go for 6 weeks with warfarin.